And just so I know, the lecture finishes at 3:50, right? Okay. If you don't mind, just like in case, like if there's before like 5 minutes, can you just like send me a text message?
Will do.
Just in case. Thanks.
So everybody, let's turn our cameras back on for the next lecture. So we have Dr. Varghese, who most of you know. He's our Associate Program Director for Ambulatory Practice, who will be presenting on thyroid disorders.
All right, thank you. So I'm going to talk about thyroid disorders, which is honestly a very big subject. So we'll try to get through as much as we can. And if we can't get through all of it, what I can probably do is send my lecture to the chiefs, and then you guys can distribute the rest of it that we don't get through, just because even when I was starting to prepare this lecture, it was very vast indeed. So what we're going to try to do is try to make this more interactive. So there's going to be some questions. So if you guys can either go to slido.com and then just do #thyroid, or just scan that QR code, you'll be able to hopefully get the questions in real time. So bear with me. This is the first time I'm using this because I saw somebody else use it. So we'll see if this can work, okay? And every time there's a question, I believe this QR code will still come up. So let's start here. So let's see if this works. So just a quick kind of icebreaker. How comfortable are you with your knowledge about thyroid disorders? All right, people are answering, yay. All right, we'll just give it a few seconds. And it looks like most people are kind of in the neutral range or moderate comfort level, which is totally okay. Or even a little bit uncomfortable. Thyroid disorders are a little bit confusing because the labs sometimes are very confusing. So hopefully we can give you a little bit of background and we can get you a little bit more comfortable. And for those who are uncomfortable and those who are moderately comfortable, get you kind of up a little bit of a level. And hopefully for those who are very comfortable, that this is just a review for you. All right. So what we're going to talk about, again, it's a lot, but we're going to try to kind of go through hypothyroidism, hyperthyroidism, thyroiditis, and even thyroid nodules. And through that, kind of go a little bit through the pathology, what the general history, physical, clinical signs and symptoms are, testing, diagnostics, and treatments. And so I think the first place to really start is the hypothalamic pituitary thyroid axis. You really have to have a somewhat of a good understanding of this axis in order to really understand how the labs work, right? So your hypothalamus interacts with your pituitary through TRH. Your pituitary then sends the hormone TSH to the thyroid gland, and the thyroid gland then produces thyroid hormone. And it produces inactive and active forms, right? So this is all useful to know. And then the thyroid hormone goes into all of the target tissues in the body. And the thyroid has its hand in a lot of the organ systems that we see. All right. And so just a quick overview, as kind of concise as we can get it, just general symptoms for hypothyroidism, right? weight gain, bradycardia, constipation, cold intolerance, depression, fatigue, changes in the skin and hair, and changes in your menses. And almost on the opposite end of that spectrum are the symptoms for hyperthyroidism, right? So weight loss, palpitations, diarrhea, heat intolerance, sweating, and changes in your menses being shorter and lighter. So obviously the first thing that we're always going to do is we're going to take a good history to find out what exactly is going on with the patient in front of us. And so on the physical exam, we'll kind of move through there, is you always want to look at the overall appearance of somebody, and paying attention to, not only their general kind of affect, but looking for things like sweating, tremors, even the outer third of the eyebrow. You want to be looking at the eyebrows, looking at the skin, looking at the pulse, looking at your eyes, or looking at the patient's eyes, right? That can show you some changes in the thyroid. And then definitely paying close attention to the neck for goiters, any kind of masses moving with swallowing. And then I've included here a video for a really good way of kind of how to do a thyroid exam. I'm not going to play it only because it's like 7 minutes and we're going to be short on time, I can tell. So what I'll do is I'll send that link out to all of you guys, but it's a really handy way to figure out how to, one, find where the thyroid is in the neck and how to do an exam of the thyroid. Obviously, you don't want to forget about your lymph nodes as well. And sometimes what we do forget about is auscultating the thyroid, because you can hear a bruit in patients who have Graves' disease. And that's due to the hypervascularity of the condition. So goiters, just a quick review, right? So that's just when the thyroid gland is growing larger. Some of the common symptoms besides the swelling is that feeling of tightness in the throat, hoarseness in your voice. You can have neck vein swelling and even dizziness when the arms are raised above the head. Goiters are classified in 2 different ways, and it's really the etiology of what caused the goiter, whether it's a simple goiter or an endemic goiter. So now we have a question here. So hold on, let me move this a little bit. Okay, so I'll just read it out for you, and then you're going to get a little thing on Slido to tell you what to do. So a 48-year-old woman with no significant past medical history presents for evaluation of fatigue and weight gain. She has been irritable, a little sad lately, but is able to continue to function appropriately in her life and work. She has not had a menstrual period in 6 months. Past medical history is back pain. Medication list is ibuprofen and a multivitamin. No family history of thyroid or autoimmune diseases. Her exam, BMI is 31, heart rate 78, blood pressure 120/74, a diffuse tender enlargement of the thyroid gland. Her hair is thin. Lateral eyebrows are absent and skin is dry. Her reflexes are 1+ throughout with delayed relaxation. You mentioned to the patient you suspect hypothyroidism and explain what that means. She asks you if it is common and if she did anything to cause it. You explain that. And so the question is, pick the appropriate test to order. And your choices are between TSH, total T4, total T3, free T4, free T3. And so let me go to hopefully the next slide. All right, so what is the appropriate test to order in somebody that you suspect may have hypothyroidism? All right, we're just going to wait a little bit to see if we can get maybe up to 25, hopefully. All right, I think the numbers have kind of died down a little bit. And so what I'm going to do is stop the poll here. And it looks like most of you have chosen TSH, total T4, free T3. The next group of you chose TSH, free T4. And then some of you have done total T4, TSH, and then the whole gamut. So the correct answer is TSH and free T4. So let's go into a little bit about what the tests are and how do we use them. So TSH is always the best initial test, whether it's hypothyroidism or hyperthyroidism. right? And then the next best test, especially for hypothyroidism, is the free T4. The total T4 is measuring both your bound and free hormone, and that could change depending on what your binding proteins are affected by. The free T4 is what's going to tell you what's actually not bound is able to enter into the bodily tissues. Some of the tests that you guys also chose, somebody I think, or some people or group chose free T3. So free T3 is actually not a very reliable test. If you guys are out in the clinic in ECW, you can see whenever you guys order thyroid panels, free T3 and reverse T3 are always available, but they're not actually very useful to us clinically. When it comes to hyperthyroid, so too much thyroid, your T3 test is actually the most useful diagnosis in addition to your TSH. So just a quick recap then, right? So for hypothyroidism, TSH and a free T4. For hyperthyroidism, TSH and T3 and T4 and a free T4 will be very helpful for you. Free T3, reverse T3, not so useful. The other test that we see on this slide, which is not very common, it's not really one of our first level tests, is thyroglobulin. And sometimes you can see that order as well. Thyroglobulin is made in the epithelial cells. It's usually used as a marker for cancer recurrence, but it can be high in certain conditions. And this could help you both clinically, but also even on test questions. So it's high in entities like Graves' disease, subacute thyroiditis, and certain thyroid cancers, because it's used as a marker for cancer recurrence, nodules, and multinodular goiter. All right. And then the other set of tests that we have are thyroid antibodies, and there's a bunch of thyroid antibodies as well. So for hypothyroidism, the main thyroid antibodies that you could potentially order is TPO or thyroid peroxidase antibody or thyroglobulin antibody. These tend to be positive in patients with hypothyroidism, especially in those with Hashimoto's thyroiditis. It's really helpful to keep that in mind for the initial diagnosis, but for these antibodies are not really useful in monitoring the progression of that type of disease. Where it's a little bit different is in hyperthyroidism. So you can see you have two different types of antibodies, the stimulatory TSH receptor antibody and the thyrotropin receptor antibody test. Both of those can be used, or you can use to evaluate hyperthyroidism. Then the thyrotropin receptor antibody test can be used to follow, assess the responsiveness of treatment in hyperthyroidism, kind of determine when it's appropriate to discontinue any kind of medication that you may be using to, let's say, treat Graves' disease. So that's the big difference between some of these antibodies. So try to keep those in the back of your mind as we kind of move through some of these questions. What are the other things in our toolbox for thyroid disease are things like thyroid ultrasound, right? But Endocrine Society, and that's the second bullet here, it says, don't routinely order a thyroid ultrasound in patients with just abnormal TFTs, unless there is a palpable abnormality of the thyroid. What you guys can see here, I'm not sure if you can see, but here's your trachea. Here's one lobe of the thyroid, the other lobe, blood vessel, and these are smooth muscle on top of that. But really, when we would use the thyroid ultrasound is if we palpate an abnormality of the thyroid or notice an abnormality of the thyroid. And one of the other tests that we have are things like radioactive iodine uptake scans and the thyroid scan. This basically is used for patients who have hyperthyroidism. And what it is it's taking radioactive iodine and it's kind of seeing how much the thyroid gland can take up. And the scan shows you the distribution of the radioactive iodine. And we'll talk a little bit more of this algorithm that's on the other side of the slide in a little bit, especially when we talk more about hyperthyroidism. And this is an example of one of these scans, and you can see there's a little bit of uptake here, not in the whole thyroid. So next question. So the patient's TSH, a patient's TSH is 50, and their free T4 is 0.1. How would you classify this patient's hypothyroidism? So this has to do with Where is this thyroid problem coming from? Is it coming from the thyroid? Is it coming from the pituitary? Is it coming from the hypothalamus? All right, let's see if we can make it to 22. 22 people answer. Almost 2 more people. All right, we got it to 22. So you guys are correct. That is primary hypothyroidism. So we'll talk a little bit about hypothyroidism. So like I said a little bit earlier, hypothyroidism can be separated out into primary, secondary, tertiary, and even peripheral resistance. And primary is one of the most common sources of hypothyroidism. And it's really a thyroid failure of some sort, right? So there's a deficit in thyroid hormone. It can be due to autoimmune causes like Hashimoto's thyroiditis, iodine deficiency, drugs or different medications, infiltrative diseases. It can be iatrogenic, so radiation therapy of some sort, or it could be transient. And transient meaning even things like thyroiditis, which hopefully we'll get enough time to talk about. So secondary causes are coming from the pituitary. This tends to be pituitary adenomas, not as common as primary causes. And then lastly, you have your tertiary causes, which is from the hypothalamus. This is very, very rare. And so our peripheral resistance, like mutations, that's very rare as well. So this is a quick way to kind of remember where everything's coming when it comes to the labs. So you guys got everything correct when we were talking about the TSH being high and the T4 being low. That's definitely characteristic of primary hypothyroidism. And then secondary would be with both lab values being low, because there's just not enough coming out of your pituitary. So let's see. So a little bit about primary hypothyroidism. So like I said, it's one of the most common causes of primary hypothyroidism. It's the most common cause in the iodine sufficient areas of the world. The antibodies, just like we kind of talked about a few slides ago, Thyroglobulin antibody, TPO antibody. It's most common in menopausal women. So this usually suggests that the absence of estrogen probably plays a role in that. Common in people with family history of thyroid disease or autoimmune disease. Some of them are environmental factors that affect Hashimoto's thyroiditis is alcohol intake, smoking, and environmental radiation exposure. So next question. A 49-year-old male presents to the clinic with a 4-month history of cold intolerance, easy fatigue, depression, some weight gain and constipation. The lab results show TSH of 0.5 and the free T4 is 0.5. Which of the following is the most likely diagnosis? Is it primary hyperthyroidism, secondary hypothyroidism, Hashimototoxicosis, euthyroid 6 syndrome? All right. So we'll stop that. You guys are all 100% correct, which is good. And the reason why you guys got that right, is your TSH is low, your free T4 is low. So both of them are low. So one thing that we commonly see in the clinic actually is people wanting to do thyroid testing as a screening test. And so any patient that has a symptom of hypothyroidism should definitely be evaluated for hypothyroidism. But screening of patients who don't have any symptoms is pretty controversial. And this is from the USPSTF, right? It's grade I. So there's not really enough evidence to support testing patients who are asymptomatic. But with that being said, as with a lot of things, there is a time when screening is appropriate. So screening of asymptomatic patients can be considered in the following kind of cases, right? So any kind of previous head neck radiation, any previous radioactive iodine therapy, risk factors for hypothyroidism, so like history of autoimmune disease, family history of thyroid disease, and treatment with drugs like lithium and amiodarone, which can influence the function of the thyroid. And lithium and amiodarone tend to be probably the most common medications that we see, both in the outpatient and probably in the inpatient setting as well. All right, so next question. You have a 48-year-old female with primary hypothyroidism. TSH is 50, free T4 is 0.1, and you decide to start treatment. What do you prescribe? So this is the same lady from like a couple of questions ago. So her weight is 72 kilograms, and your options are Armour thyroid, levothyroxine 50, levothyroxine 115, or obtain TPO antibodies prior to starting treatment. All right, let's see if maybe we can get a few more people. So it looks like everybody is kind of fluctuating between two of the choices. So levothyroxine 50 or obtain TPO antibodies prior to the start of treatment. And so, well, I'm going to shut off the polling now. We'll go to the next slide. So the answer is actually levothyroxine 115 micrograms daily. So let's talk about why that answer is correct of starting treatment. And I will say the reason why you don't need to get the TPO antibodies prior to starting treatment is you don't need it to start treatment. TPO antibodies is going to be helpful for you diagnostically to tell you, does this person have Hashimoto's? Do they not have Hashimoto's or some other reason for the hypothyroidism? So let's talk a little bit about treatment, right? So once you have synthetic thyroid in your body, it's just going to be seen by your body as regular thyroid. So your choices of medication are levothyroxine, Synthroid, and Armour thyroid. And so for patients younger than 60, so that lady in our question was 48. You want to start somewhere between 1.5 to 1.8 micrograms per kg per day. And so most people, and even if you check like up to date and me, myself in practice, I usually start with like 1.6, kind of right in the middle. If the patient was older, right? So if they're over 60 years old, or they know, or you know that they have some sort of heart disease, you're going to start lower. Somewhere between 12.5, which is the lowest dose of levothyroxine, and 50 micrograms. So somewhere in between there, most people kind of start at 25 or 50. I have rarely seen somebody start at 12.5, but it is possible. The other thing, which we're not going to talk about too much, but thyroid disease in pregnancy, it is going to increase your thyroid requirement. And so what you would have to do is increase the dose number. So normally you get 7 doses in a week, but you would increase it to 9 in order to accommodate the increased needs during pregnancy. So let's go to the next slide here, which you may or may not know. So in 2004, the FDA approved that generic levothyroxine can be substituted for the brand name. So the brand name is Synthroid. However, also during that year, the American Association of Endocrinology and the Endocrine Society and the American Thyroid Association disagreed with the FDA's conclusion that the generic and the brand are equivalent. So most things in medicine, the generic and the brand tend to be pretty equivalent, but this is one of these times where the brand and generic are not really equivalent. And so the recommendation from the Endocrine Society, American Thyroid, these endocrine societies in general, is that once you start somebody on a medication like Synthroid, you should continue them on Synthroid and treat the other medication like levothyroxine as almost like a different type of medication. And you shouldn't use them interchangeably. Like sometimes we use let's say a statin, Lipitor and atorvastatin. Sometimes we use those interchangeably, but when it comes to thyroid replacement, we shouldn't be doing that. And that has to do a lot with kind of the pharmacomechanics and the pharmacokinetics of the two types of medications. So something to just be aware of, that you don't really want to be switching between the two for one patient. So let's go to the next question. So we have a 75-year-old woman who has been taking 1 grain or 60 milligrams of desiccated thyroid extract daily for 15 years. She feels great and denies hyper and hypothyroid symptoms. She will not take any other type of thyroid medication. Exam is normal. Her labs, TSH is 1.3. Her free T4 is 0.5. Her free T3 is 2.3. Which of the following should you recommend? A, measuring antithyroid antibodies. B, decrease the dose to 0.75 grains. C, measure total T3. D, increase dose to 1.5 grains. Or E, make no changes. This is a little bit tougher, only because we're talking about desiccated thyroid extract. So if you don't really know, take your best guess, and we'll go from there. All right, so it looks like a majority are saying make no changes. The next majority is increasing the dose. And then the other part of you guys are saying measuring more lab tests. And some of you are saying to decrease the dose to 0.75 grains. All right. So the answer is actually make no changes. And we'll talk a little bit about the reasoning why. So what is desiccated thyroid? You may not see it very often, and it's not something that is often prescribed, especially in our clinics or in the hospital or by endocrinologists. So Armour thyroid is a mixture of T3 and T4, and it's coming from a porcine thyroid gland that's pretty much mashed up and put into a pill. So you're not really going to know how much T3 or T4 is in that tablet. TSH is the most sensitive marker to assess the adequacy of the dose, right? And the reason why, just like I just said, is that T3 and T4, it's too variable inside of those tablets. Some of the reasons why patients may like it, because in that question stem, it said the patient doesn't want to change and she really likes that medication, is that it's considered quote unquote more natural because it's not manufactured really, because it's coming from a pig thyroid gland. And so patients tend to, who may gravitate towards more natural types of medications, can gravitate to Armour thyroid. But it's very difficult for us to interpret what happens when somebody's on Armour thyroid. It's definitely not recommended by the American Association of Clinical Endocrinology or even American Thyroid Association for the treatment of hypothyroidism. And there have been some trials or RCTs about combination therapy versus monotherapy with just T4. And it showed that there really is no improvement by adding the T3 with the T4 in any of the symptoms or quality of life in hypothyroidism. So the reason why it was make no changes in that last question is because this patient's TSH was fine. So if their TSH is fine, you don't need to make any changes whatsoever. And you don't want to, sorry, before we get to that, and you don't want to check the other lab values because it's not really going to help you because it's so variable. And it depends on when patients take their Armour thyroid before or after their lab test, and that's how variable those things are. So that's why we don't tend to use T3 or T4 when looking at Armour thyroid. Okay, so next question. So we have a 56-year-old woman comes in for a checkup and routine PAP. She reports mild fatigue, but continues with a very active lifestyle. She plays tennis 1 day a week. She has a 2-mile brisk walk almost every single day. no past medical history. She doesn't smoke. She is taking over-the-counter calcium supplements. Her physical exam's unremarkable. Her labs, you can see her BMP looks pretty okay. Her glucose is 92. Her TSH is 10.6. Her free T4 is 0.9. Her anti-thyroid antibodies are positive. Her lipid panel shows that her LDL is 170, HDL is 41, triglycerides 107. Which of the following is the best plan of action at this time? A, order a 75-gram oral glucose tolerance test to rule out diabetes. B, begin levothyroxine 50 micrograms per day and check lipids and TSH in 2 to 3 months. C, start a statin. D, reschedule or revisit appointment in 1 year. All right, let's see if we can get our polling numbers up a little bit more. So let's say 20 more seconds. All right, so it looks like we've settled that 75% of you are going to begin levothyroxine, check lipids and TSH in 2 to 3 months. The next percentage of you will reschedule in 1 year. And some of you are saying to start a statin or order a 75-gram oral glucose tolerance test to rule out diabetes. All right, so let's go to the answer. So the answer is begin levothyroxine and check lipids and TSH in 2 to 3 months. So the reason you wouldn't want to revisit in 1 year is, don't forget, this person's TSH is now over 10 and their free T4 is low. So you don't want to let that kind of sit there without addressing that. In terms of A, the glucose tolerance test, we don't really use that so often as a diagnosis. Her glucose also isn't that high, so I probably wouldn't go with that one. And for those who chose C, start the statin, the one thing to know is that being hypothyroid can affect your lipid panel. And so it makes sense to treat your thyroid disease prior to treating your cholesterol disease, because they're tied together that way. So let's go here. So how often would we do some treatment monitoring, right? You can see some symptom improvement within 2 weeks, but usually it takes about 4 to 6 weeks, if not a little bit longer. You always want to check your TSH within 4 to 12 weeks of initiating, or even if you make a change in the dose. And if your TSH is still high, you're going to increase the dose by 12 to 25 micrograms, and then repeat the TSH in about 6 weeks. But before you make the change, I think we have another question coming up. So we have a patient here who has been controlled on a stable dose of levothyroxine for several years. She recently started taking calcium, vitamin D, and a multivitamin every morning together with her long-term hydrochlorothiazide and levothyroxine. What is the most likely reason for a newly increased requirement of thyroid hormone supplementation in a perimenopausal woman with Hashimoto's thyroiditis? The answers are A, progression of Hashimoto thyroiditis, B, co-administration of levothyroxine and calcium, C, a change in the estrogen level, D, drug interaction with hydrochlorothiazide, E, development of a partial adrenal insufficiency. All right. So the question is really asking, what is the change why is there a change in the TSH? right, let's see if we get maybe a few more people, about 15 more seconds. All right, so it seems like you guys will have almost a 50-50 split on the change in estrogen level or the co-administration of levothyroxine and calcium, and with a small group of you saying a drug interaction with hydrochlorothiazide. So the correct answer is actually the co-administration of levothyroxine and calcium. So the change in estrogen level, which some of you guys were choosing, you have to be careful because estrogen can play a role in Hashimoto's, but the one thing you have to remember is up here in the question stem, she's been well controlled on a stable dose for many, many years. You also don't really know what her age is because nobody said what her age was. So you don't know if she's perimenopausal or menopausal. All you know is that she's had a stable dose for many years. And so the estrogen level, it's a tricky question because it potentially could be had they given you an age, but they didn't. And so that's the reason why that answer is incorrect. The reason the answer is B, the levothyroxine and calcium, we'll talk about a little bit about medications that decrease the absorption of levothyroxine. And then a small group of you said there was a drug interaction with hydrochlorothiazide, but there is no drug interaction there. So whenever we're assessing the reasons TSH can be abnormal, the first thing we're always going to assess or should assess adherence, right? Is somebody missing a dose of their thyroid medication? And is that the reason why the TSH is abnormal? Levothyroxine and Synthroid both have pretty long half-lives. So just missing like one dose in like a couple of weeks probably is not going to do anything to your TSH. But if you're missing multiple doses, if you're missing weeks worth, then that is going to play a role in the change of your TSH. The other thing we always want to ask is if there's a change in the timing of the medication relative to eating. This has a lot to do with things that can decrease the absorption of levothyroxine, so things like iron, calcium. And this is why probably even in the hospital, there's a little note into when to give your thyroid medication, right? You always want to do that first thing in the morning before you eat anything, and then you can eat at least like 30 to 45 minutes after. The other things that you want to kind of take a look at that could be affecting that TSH is malabsorption. So syndromes that can cause that, right? H. pylori, celiac disease, these tend to be more common than autoimmune trophic gastritis or diabetic gastropathy, and medications. And so it came out a little bit blurry on this slide now that I'm looking at it, but calcium carbonate, ferrous sulfate, multivitamins that contain those can all change the absorption of levothyroxine. So when you're looking at a lab, you have to assess kind of all those things like adherence, when they took their medication, any kind of malabsorption syndrome, any new medications, because that can change your thyroid level or your TSH. I'll give you a quick caveat. So I remember having a patient who a TSH, and she was on thyroid medication, and a TSH was checked by her cardiologist, and her TSH came back as, I think, 30. And the cardiologist sent her back to me and said, hey, the TSH is 30. Do we need to change the thyroid medication? Which is very bizarre because all the times I checked the TSH, it had been normal. And the one thing I found out was that the cardiologist actually started that patient on magnesium, and the patient was taking the magnesium and the levothyroxine all at the same time. And so once we figured that out, I told her to space it out. The next time we checked her labs, 4 to 6 weeks later, her TSH actually came back to normal. So I didn't change anything with her thyroid medication at all. I just told her to space out her supplement. So you can see that there can be huge changes in your TSH with just the small change of something that may not seem as important at the time, but it can make a huge difference in thyroid disease. So what about patients with persistent symptoms? So these patients are defined as those who are treated with an adequate dose of levothyroxine and report persistent symptoms, despite having normal biochemical levels. And so when that happens, then we need to start investigating other causes of the symptoms, as it probably is not the thyroid. And here on this slide, you can see there's a whole bunch of different reasons why you could still have these symptoms, symptoms of hypothyroidism. And the one thing I wanted to kind of bring to your attention, even though we were just talking about armor thyroid and how T3 and T4 combos don't really mean anything, every once in a while, you may run into a patient who is on a combination of T3 and T4, or levothyroxine and cytomel. And sometimes older physicians or a patient who's been on these medications for a while, there was a time period where one of the things patients or providers would do would be to add T3 if you had persistent symptoms. Now, these trials are more recent, right? So that's why you found that there is really no difference between them and we shouldn't be adding them. But I just wanted to make you aware that sometimes you'll see patients on that. And then at that point, we should try to educate the patients to say that you probably don't need that extra T3, only because it's not really going to make any big difference in the way that you have symptoms or your quality of life overall. All right, so I think we have next question. So you have a 92-year-old female who's presents for follow-up. She's well on reports, no fatigue, constipation, or weight changes. Brings in records showing that her TSH was 5.5 4 years ago. Today, her TSH is 7, free T4 is 1.2. Her thyroid is normal on palpation. What is the most appropriate management for this patient? So A, recheck the TSH and free T4 levels in 6 to 12 months. B, check the thyroglobulin level. C, perform a thyroid ultrasound. D, initiate treatment with levothyroxine 25 daily and adjust the dose to achieve a TSH level between 1 and 2. E, initiate treatment with liothyronine, so that's the T3, at 5 daily and adjust the dose to achieve a TSH level of 3 to 5. All right, let's give you another 15 seconds, see if any more of you can answer. All right, so it looks like a majority of you have chosen recheck the TSH and free T4 in 6 to 12 months. And then the next percentage want to start medication and then adjust the dose based on TSH. All right, so the correct answer is recheck the TSH and free T4 levels in 6 to 12 months. And the reason why is this person actually has subclinical hypothyroidism. And you can see that with their TSH is 7, so it's less than 10, but above 5. And the free T4 is in the normal range. So subclinical hypothyroidism is something that you tend to see a little bit more in, I think, the outpatient setting, right? The prevalence is between 3 and 15%. And the diagnosis, just like we just spoke about, is you have an elevated TSH and a normal T4. Patients may or may not have symptoms attributed to hypothyroidism, and you can have an elevated TPO antibody titer, and that increases the risk of progressing to overt hypothyroidism, even when the TSH level is less than 10. So when the TSH level is less than 10, that's about 75% of patients with subclinical hypothyroidism. In 50% of patients with a TSH less than 7, the TSH will normalize within 2 years. If your TSH is greater than 10, you're more likely to exhibit symptoms. And about 33 to 55% of patients with subclinical hypothyroidism will progress to clinical disease. So the risk of of progression to overt kind of hypothyroidism is about 2 to 6 per year. And there's some factors that kind of increase your risk to that progression. So if your TSH is greater than 10, you're most likely going to convert to overt hypothyroidism. And if you have the presence of autoantibodies like the TPO antibodies. So the goal of treatment for subclinical hypothyroidism is decreasing symptoms if somebody has it, and decreasing the likelihood of long-term consequences. So when would you treat somebody with subclinical hypothyroidism? So if their initial TSH level is greater than 10, then you would treat them. So in the patient that we had, her TSH level was 7 and she didn't have any symptoms. Patients with elevated TPO antibodies, you can treat them. Why? Because there's a higher risk of progression to overt hypothyroidism. Patients who have symptoms suggestive of hypothyroidism with their TSH levels between 5 and 10, and patients who are pregnant or attempting to conceive. So we're going to switch gears a little bit. I think we only have probably 10 minutes left, maybe 5 minutes left. So hopefully we can get through at least some of the hyperthyroidism slides and questions. So hyperthyroidism is basically too much thyroid hormone in the tissues. And it's usually caused by three types of ways, right? Either an increased synthesis of thyroid hormones. So those are things like Graves' disease, toxic multinodular goiters, toxic adenomas, or excessive release of preformed thyroid hormones. So things like thyroiditis. The third cause, not as common, but sometimes ends up on test questions, are an exogenous use of thyroid hormone. All right. So like we kind of talked about with hypothyroidism, we're always going to do a TSH. And so how you want to kind of evaluate hyperthyroidism is a little bit kind of person dependent, meaning that you're obviously going to order a TSH. Some physicians wait for a TSH first, and then based on that, order the next kind of set of tests. And some physicians will order a TSH, but then they'll also order the total T3 and the free T4 levels. So these are the 3 tests that you would use for hyperthyroid evaluation. Let's see. And if you're out in the clinic we have TSH with reflex to free T4. So if the TSH is abnormal in either situation, hypo or hyper, so it's elevated or decreased, it'll reflex itself to the free T4, and then you're going to have to add in the other test. Let's see. Okay, so we have a question here. So you have a 79-year-old woman who comes in with her daughter. The patient states she is fine. The daughter confirms that there is no difficulty swallowing or breathing, no changes in the mother's voice. The family reports weight loss, irritability, and anxiousness. On physical exam, the heart rate is 104 and regular, tremor in her outstretched arm, and enlarged heterogeneous thyroid. Trachea is not deviated. She can't resist your pressure against raising her leg from the exam table. Her labs show TSH 0.1, free T4 17. Which of the following is the most appropriate evaluation or next step? A, thyroid scan. B, thyroid ultrasound. C, MRI of the head. D, CT of the neck. E, thyroid scan and radioactive iodine uptake. All right, let's give it another 15 seconds. So here it looks like you guys have, again, almost a 50-50 split between thyroid scan and radioactive iodine uptake, or thyroid ultrasound. So the correct answer is thyroid scan and radioactive iodine uptake. The reason why your thyroid ultrasound is not the correct answer is, one, this person does have hyperthyroidism, but also you just have an enlarged thyroid. So there's no palpable abnormality there. So you probably wouldn't choose that. but the main reason is because you do have hyperthyroidism there. So we'll kind of walk through the diagnostic workup of hyperthyroidism. So you're going to obviously do your history and physical exam, do your kind of first set of lab testing with your TSH, then your free T4 and total T3 levels. And then the next step from there would actually be to take a radioactive iodine uptake and scan of the thyroid gland. And here, this is going to help you figure out the etiology of what's causing your hyperthyroidism. So I always remember things a little bit better if I always remember the one that's always low in the uptake scan, and that's always thyroiditis or exogenous thyroid hormone use, and everything else is high. So things like Graves' disease, toxic adenomas, multinodular goiters, those are always going to have a high radioactive iodine uptake. And the scan is going to tell you how that iodine was taken up by the thyroid. Was it all over, or was it in a very concentrated spot? And so Graves' disease will give you that tracer in a kind of diffuse pattern, whereas the adenoma and the multinodular goiter will be very specific spots in your thyroid. So that's that. All right, so let's go for another question. So we have a 25-year-old female nursing assistant, has a 2-month history of palpitations. She is trying to lose weight. Her thyroid is not palpable. She has a fine tremor. Labs are TSH 0.01, free T4 2.1. She has an undetectable thyroglobulin level. What is the most likely diagnosis? A, subacute thyroiditis, B, toxic multinodular goiter, C, hot nodule, D, surreptitious use or extra use of thyroid hormone, E, Graves' disease. All right, we'll give it another 10 seconds if anybody else wants to answer. All right, you guys are correct. She's using extra thyroid hormone. So there's 2 ways you could have figured that out. One is there's always clues in your question stems. So she's a nursing assistant, so that means she has access to potentially extra medication. So that's one clue. But the other clue is the undetectable thyroglobulin level. So we talked about way in the beginning of the lecture that thyroglobulin levels can be high in certain conditions, and it happens to be high in subacute thyroiditis, multinodular goiters, Graves' disease, and not hot nodules. So by knowing that, just that one piece of information, you know that the answer is actually going to be D. All right, so next question. We have a 28-year-old woman presents with fatigue, heat intolerance, and weight loss. Physical exam, heart rate 101, blood pressure normal. She's tachycardic with warm skin. Her TSH is 0.02, free T4 is 2. Her radioactive iodine uptake is diffuse uptake of 42%, so it's high. What is the most likely diagnosis? A, postpartum thyroiditis, B, subacute thyroiditis, C, iodine excess, D, amiodarone use, E, Graves' disease. All right, we'll give you another 5 seconds if anybody else wants to answer or throw in an answer. All right, so a majority has chosen Graves' disease, and then a small percentage has chosen subacute thyroiditis. The correct answer is Graves' disease. So the reason why it's not subacute thyroiditis has to do with the radioactive iodine uptake. So this is high and it's diffuse. So when it's high, it's going to be Graves' disease, and when it's diffuse, it's going to be Graves' disease. So subacute thyroiditis has low uptake. So does postpartum thyroiditis. So those will have a lower uptake. And so that's how you can eliminate those altogether. So Graves' disease will go quickly, right? Is an autoimmune process, basically, where the antibodies stimulate the receptor to produce more thyroid. The radioactive iodine uptake scan and the scan can help you distinguish if something's Graves versus something else. And then there's some physical exam findings that are really pathognomonic for Graves. So changes in the eye, pretibial myxedema, clubbing of the fingers and toes, and goiters can also develop in Graves' disease, usually smooth, and you can have a thrill on palpation or bruit on auscultation, like we talked about in the very beginning. So we'll talk quickly about hyperthyroidism treatment, only because I know we only have a few minutes left. So your choices are beta blockers, antithyroid medications, radioactive iodine ablation, and thyroidectomy. So your antithyroid medications basically inhibit thyroid peroxidase, so blocks the synthesis of T3 and T4. They can serve as a long-term therapy or as a bridge between ablation and thyroidectomy. When you're using these medications, you're going to monitor the free T4 and total T3 every 4 weeks after starting the thionamide, and then every 4 to 8 weeks after. And then you're going to adjust your dose based on these results. So you're not using the TSH for monitoring. You're using free T4 and total T3. You would continue these medications for 12 to 18 months. And then after that, as long as the TSH is normalized, then you can start taper or discontinuing the medication. Once it's discontinued, there is a relapse rate. It occurs in 30 to 70% of people within the first year. And then you always want to, after you discontinue, you're still going to monitor your thyroid function 1 to 3 months for the first year. All right. For radioactive iodine ablation, this is most commonly used for treatment for Graves' disease in the United States. There are some contraindications. So if you have any kind of moderate to severe orbitopathy, you're not going to use radioactive iodine ablation. If you're pregnant, you're going to use radioactive iodine ablation. It takes about 12 weeks to achieve the full effect. And because of that, sometimes you can start patients on those antithyroid medications. But before you do that, if they're already on it, if they're bridged, then you're going to discontinue the methimazole or the PTU 5 days prior to that. And then thyroidectomy, that's really reserved for patients who have a goiter that's causing compressive symptoms, or if the patient has contraindications for radioactive iodine or the antithyroid medications. So here you can see just a quick table of all of your medications. Even has some of the costs there. The one thing to remember for methimazole and PTU is how they relate in pregnancy. So methimazole, you're not going to use in the first trimester of pregnancy. PTU is the drug of choice in the first trimester. But PTU does carry a high risk of liver issues, so you do have to be careful with that medication. And then we'll go here. And so the one thing to just remember is for hyperthyroidism is regardless of the cause, you're always going to treat the adrenergic symptoms with beta blockers. They're usually controlled pretty well with beta blockers. For Graves' disease, you can use antithyroid medications or radioactive iodine ablation or thyroidectomy, depending on the case. For thyroiditis, so subacute thyroiditis, painless thyroiditis, usually it's just a self-limited condition. So you're only going to treat the adrenergic symptoms with beta blockers. And for toxic adenoma, toxic multinodular goiters, you're not really going to use your medications, your antithyroid medications. They can control it, but they're not going to really stop the reason why a patient is hyperthyroid. So usually these entities tend to have radioactive iodine ablation and thyroidectomy as their mainstays of treatment. So with that, I know we have another question and I actually have a lot more slides, but what I am going to do is I'll stop the lecture now